Good afternoon, everybody. Thank you for coming to this Dean's Lecture, and I'm really impressed so many people are here because usually it's across the hall. It took me 5 minutes to figure out it wasn't there. So thank you all for coming, and I think it's a testimony to Elizabeth's collaborative spirit and the fact that she works with so many people, that we have so many folks here. So this is the point, for those of you who haven't attended these before, where I introduce the speaker to people who know her far better than I do, okay? But I still have to do this as a ritual. And just to say that it's not easy to be appointed to the faculty of Johns Hopkins University into our school, but to be promoted to professor is really a very high bar. And so as somebody who is jaded and cynical about many things, I'm not jaded and cynical about this. It's a great accomplishment. And I think almost everybody in the room knows that the decision isn't made by me or the department chair or the A&P committee. It's really a decision that's made by peers around the world. We solicit their input and we get their input. And it's really those letters that make the decision of whether somebody should be promoted. And in Elizabeth's case, those letters were really outstanding. So let me just tell you a little bit about her. She is from New Hampshire. She went to Smith College and majored in math with a minor in chemistry, and then went to Harvard to the Department of Statistics and got a master's and then a PhD. And from there, she went to Mathematica and worked there for a couple years before we were fortunate to recruit her to our faculty. And I can remember very well when she was being recruited, because I had two department chairs come to talk to me about her, Scott Ziegler and Bill Eaton. And she has, as you know, is a professor in the Department of Mental Health with a joint appointment in biostatistics, but bridges those departments and many more. When you look at her CV, she has an amazing track record of collaboration. And so collaboration not only in the scientific sense, but in professional organizations. So the American Statistical Association, she's held a number of leadership positions there, won their Mid-Career Development Award. I think Mid-Career Award is the name. Yeah, and health policy. And so, and as all of you know, and I think you're going to tell us about the various things that you do. But now I have to get my notes here. So, and let's see here. Okay. So Elizabeth is unusual. And do you mind if I call you Elizabeth? Do you rather call me? Liz? Okay. Okay. So is unusual in that she spans such a broad range of interests. So I think everybody knows that she's skilled in statistical methods, especially in causal inference. She's written high-impact papers about propensity scores, but also cares deeply about mental health care delivery, policy, and educational policy. So sort of three areas that, applying her methodologic skills, she's had a major impact. Okay, and so we have a new podium here that has this giant screen on. I don't know how you use it. So, let's try this. Okay. Yeah, there's no place to put the paper. That's why, this is done by the staff so that I don't take a long time speaking here. But I'm just going to look at my notes and see what other things I want to point out. So she has over 100 peer-reviewed papers, 8 book chapters, numerous invited presentations, and she's funded by, I think, every federal agency known to man. So there's not many people who, at our school, at least, who have grants from NIH, from the U.S. Institute of Education Sciences and National Science Foundation, and she's been on advisory panels for the National Academy of Science and the U.S. Department of Education. She's now chair of the PCORI, the Patient-Centered Outcomes Research Institute's inaugural clinical trials advisory panel. So she was appointed to professor, I guess, just about a year ago, which is about the time lag it takes to schedule these. And I'm very proud that she's loaned her expertise to the Wendy Clagg Center for study of autism and developmental disabilities. She's the associate director, and she's co-director of the Center for Mental Health and Addiction Policy Research, and the co-director of the Methods Core with the Center for Prevention and Early Intervention. She's a fellow of the American Statistical Association, and has been here, I guess now, just 2005 you came? 2006? So 2006. So just, just 10 years. So please join me in welcoming and congratulations Liz Stuart. Okay.
Can you all Can you all see me? Thank you so much. It's really an honor to be here. And that's like the worst seat. Exactly. We thought about getting a box, but I might have fallen off. No, it's really such an honor to be here and to see such a wide spectrum of people who I've worked with and the wonderful connections and things from across the school. And thank you, Dean Clegg, for such a generous introduction. It's really, again, just an honor to be here and be able to tell you about my work. And again, so I span multiple departments, which is one of the things I really enjoy about being here. And so what I'm going to try to do in this 45 minutes is sort of give you an overview for my work. I think this sort of lecture is a really nice opportunity to take a step back and sort of think, okay, what are the things that really tie my work together, and how do I want to convey that to you all in the room as public health researchers and practitioners, but then also to, for example, my parents who might watch this video afterwards. So that's what I'll try to do, is sort of give you an overview for what I do and how it sort of all fits together. I do also fully acknowledge, so I was hired here into mental health and biostatistics and now have a joint appointment in health policy and management, and have just felt incredibly supported by all three of those departments in the time since I arrived. And so I just really want to acknowledge the leadership and just the environment here. Okay, so what the general thing that I think ties a lot of my work together is an interest in estimating population causal effects. So for public health and public policy purposes, we often want to know about the broad population effects of maybe risk factors, for example, lead exposure, interventions, maybe flu shots, or policy changes, maybe handgun control laws or some other policy change. What I'm focused on in this talk and a lot of my work is sort of this question of what is the best decision for the population? So there's a lot of interest right now in sort of what works for whom. I actually sort of take a different tack of kind of, if we're going to make a broad policy recommendation or sort of be thinking about population effects, what is the best decision for the population? And I'll formalize this a little bit in a second, but sort of the idea of causal inference is sort of if we expose a population of people to this treatment or risk factor or exposure, what is the average outcome as compared to if we don't expose that group of people? So to make that a little bit more formal, for those of you not familiar with sort of the idea of potential outcomes and causal effects, estimating causal effects means trying to compare what are called potential outcomes. So what I was just saying, sort of what would happen under one state of the world, the one, for example, with some intervention or some risk factor, and then a world sort of under another state of the world, for example, without the intervention. So we all know exactly this kind of idea from popular media. So It's a Wonderful Life is a perfect example of this. So in It's a Wonderful Life, George Bailey has a crisis of confidence and sort of thinks, what is my value to the world? And he knows the world as he's lived it, and you sort of, in the movie, we see the world as it exists with him in it. And then he has an angel Clarence comes down and shows him what the world would have been like had he never existed. So it's this idea of the sort of what's sometimes called a counterfactual or the other potential outcome. Kind of we see two different worlds, the world with George Bailey and the world without George Bailey, and we can compare those to say what is sort of the causal effect in some sense of George Bailey living. The problem is that we don't have the angel Clarence coming down to show us the world under alternate scenarios. So again, most of my work focuses on how do we learn about causal effects in this sort of scenario where we don't have a magical angel coming down. So any of you in this room probably kind of have it in your head that, well, randomized trials are sort of the way to estimate causal effects. So in a randomized experiment, we randomly assign who gets the intervention of interest and who doesn't. And what that gives us is an unbiased effect estimate for the people in that study. So for the people in that study, we know what the average outcome would be under the treatment and under some comparison condition. The reason for that, sort of intuitively, is that if we see some difference in outcomes, it must have been due to the treatment. It couldn't be due to any other sort of pre-existing differences because there weren't any. The treatment and control groups were completely equivalent. They were randomly assigned before we assigned the treatment, So a difference in outcomes must be due to the treatment, not due to any other characteristics or factors. So this is known as internal validity. Again, we get an unbiased effect estimate for the sample of people in the study. But there's a second piece of validity that in the causal inference world known as external validity. So there's increasing concerns in a lot of fields about what's called external validity. So external validity relates to whether the results you see in one particular sample might carry over to some relevant target population. So in particular, you can have external validity bias if a randomized trial sample differs from some target population on factors that also relate to the treatment effects themselves. And I'll come back to that later, but in some work with Rob Olson and Larry Orr and Steve Bell at Apt Associates, we sort of lay out a framework for thinking about that. And one of my premises in a lot of my work is that when we're interested in population effects, we might care just as much about external validity as internal validity. Or at least we should think about external validity. We're used to thinking about internal validity, but when we're interested in projecting effects in some target population, we need to also think about external validity. And a lot of my sort of way of thinking about this is formalized in a paper with Kosuke Imai and Gary King, where we explicitly lay that out and sort of express the bias, an overall bias in an overall population effect as a combination of the sort of internal validity bias and external validity bias. I mentioned briefly, again, there is sort of increasing awareness of this concern and increasing awareness that randomized trials are often not representative of the populations that we care about. So again, I kind of straddle worlds, and in education research, I've documented with some collaborators that the school districts that participate in large-scale federally funded evaluations are much larger and poorer than your sort of average school district across the US. Maybe more central to public health with Ramin Mojtabai and a student, Ryoko Suzukita, and some other collaborators here at Hopkins, we've documented that in drug abuse treatment, we see that the people who participate in trials of drug abuse treatment were generally sort of had higher education levels and were more likely to be employed full-time than are the individuals seeking drug abuse treatment sort of nationwide. In general, there's also increasing concerns in a lot of areas about the lack of minority participation in trials. So again, just general concerns that the people who participate in trials, who agree to be in a randomized experiment, might not reflect the people that we actually care about for some policy decisions. So what I'm going to talk about is sort of, are there ways that we can have studies with high internal and high external validity? So this is what motivates a lot of my work, is thinking through both of these factors and helping to design studies that kind of give us both of these characteristics. So I'm going to briefly talk about a couple experimental design options and then some non-experimental options and then sort of combining the two. So in an ideal setting, we would have a randomized trial in a representative population. So we would be able to have a population of people, we would randomly select from that population, and we would then randomly assign people to treatment or control. This is ideal and often not feasible. So the only examples I know of this happening, at least in a fully formal statistical way, are evaluations of large-scale government programs where basically the government can mandate that people and sites participate. So two examples are the Head Start Impact Study and Upward Bound Evaluation. I worked on the Upward Bound Evaluation when I was at Mathematica. Both of these are government programs that have sites, and what they could do is mandate sites to participate in the trial, and then people who applied to those programs at those sites were randomly assigned to get in or not. And so the results from these studies are, you can weight the sample in a formal way to be formally representative of the applicants to these programs nationwide. So it can happen. It's rare. It's very expensive to carry out. So it's usually not a feasible strategy. So instead, there's a big push in a lot of fields towards what are called pragmatic randomized trials. So pragmatic randomized trials, in some sense, are a sort of informal way of trying to get to that formal representativeness. This has been particularly true in mental health. So in mental health, there's two examples of this in particular, one called CATIE, the other STEP BD. These were very large-scale trials of treatments for schizophrenia and bipolar disorder. The main idea is basically to conduct the trial in as real-world settings, as real-world as possible, and in as broad a range of settings as possible. So rather than just enrolling subjects from Hopkins and Harvard and UNC, they go out and really make an effort to also enroll maybe smaller scale, hospitals from community settings around the U.S. Try to enroll a broad range of patients, not just those with some very narrow inclusion and exclusion criteria. A sort of fairly extreme version of this, so Dean Clegg mentioned I do some work with PCORI, and PCORI has this whole network called PCORNet, which is a network of networks. So what they're trying to set up is a administrative structure of data where basically a whole bunch of different health systems around the US will have a common data model for their electronic health records, or at least a subset of their electronic health records. And the idea is to conduct randomized trials within that infrastructure. So they're just starting the first one of these. It's called Adaptable, and it's a trial of high versus low dose aspirin as secondary prevention for coronary artery disease. And the idea is they're going to have, I forget actually the sample size, but let's say 200,000 people from a whole range of settings across the US. They'll be randomized to high versus low dose aspirin, and the idea is it will be embedded in their clinical practice as much as possible. So they might, there's ethical issues and consent, and we can talk about that later. But the idea is to sort of, again, just have as broad a spectrum of people as possible and have it be as sort of real world as possible. PRACY and PRACY2 are two frameworks for thinking about pragmatic designs and how to make trials as pragmatic as possible. But again, this is sort of one way people are trying to make trials more representative of clinical practice more generally. So what if we can't randomize, though? Those are maybe what we might try to do, but what if we can't randomize, or at least not in the relevant population that we really care about? So I'm now going to talk through two case studies of projects I've worked on with people here at Hopkins, comparative interrupted time series and then propensity score methods, both of which are ways that we can try to estimate these population treatment effects in non-experimental settings. Okay, so the first case study I'll talk through is comparative interrupted time series. So this approach is useful when there's sort of an abrupt policy change. And essentially, it's sort of a smarter way of comparing pre versus post. So we can sort of see what was happening in the pre-period, project what would have continued happening in the absence of some policy change, and compare outcomes with what we saw actually happened. It's best if you can have comparison sites to use to sort of see what was happening over time, and I'll show an example of that in a minute. I wanted to give a quick reference to some work with Colleen Berry and Beth McGinty, who are sitting right here, and others, where we're using this general approach, an interrupted time series approach, to look at the effects of a federal law. So the US had the federal mental health parity law in about 2010, which said that health insurers have to cover mental health conditions at the same level that they cover physical health conditions. So if they have treatment limits on mental health conditions, they would have to have the same treatment limits on physical health, so the number of inpatient days or the number of visits. So the idea was that this law was supposed to increase access to care and reduce sort of limits on mental health care paid for by insurance. I'm not going to get into the details of that, but happy to talk in more detail. But as one example of the results from that, in a paper that is sort of just under review, we're finding that for children with autism spectrum disorders, the law increased service use a bit without increasing out-of-pocket costs by their families. So it's sort of, the law seemed to be effective at doing what it was designed to do. So increasing the amount of services that kids received, but without increasing the financial burden borne by the families. What I'm going to talk about in a little bit more detail, though, is an example from gun control. So I don't think Daniel Webster's in the room, but I'll cite that in a second. So on January 5th, 2016, President Obama announced new executive actions around gun control. So, and in his statements, he said, In fact, we know that background checks make a difference. After Connecticut passed a law requiring background checks and gun safety courses, gun deaths decreased by 40%. So what I'm going to tell you about in about 5 minutes is the research study that sort of underlied that statement. So the law underneath that was that in 1995, Connecticut passed a permit to purchase handgun law. And the law, permit to purchase laws in general require individuals to get a permit to purchase a handgun, which involves a background check, fingerprint, safety training, etc. And so what we're going to do is this a paper by Kara Rudolph. Some of you might know. She was a EPI PhD student and then a postdoc with me. She's now doing the Robert Wood Johnson postdoc out in California. This is a paper that came out in American Journal of Public Health. So it's joint work with her and Jan Vernick and Daniel Webster. So what we did was we used data on homicide rates from 1984 to 2005 for Connecticut and 39 states that were kind of at risk for implementing such a law. So these were states that did not have a permit to purchase law in 1995. And fundamentally what we're going to do is compare the trends and changes in Connecticut with trends and changes over time in the other states. What we're going to use is a sort of more sophisticated interrupted time series approach called synthetic controls. So in general, comparative interrupted time series uses the trends seen in the comparison states to help sort of guess what would have happened in Connecticut had it not passed its law. This will generally work better, and there's some sort of theory and details underlying this statement that I'm not going to get into, but this generally works better if the comparison states are a good proxy for Connecticut. That basically if sort of they look like things were happening in similar ways before the law change, and then we sort of compare that, what happened in those states to what happened in Connecticut. So in particular, what this synthetic control approach does is it reweights the comparison states to best match the trends that were happening in Connecticut during the pre-law period. There's some benefits of this approach, especially in a sort of high-stakes setting like gun control research. In particular, it's a data-driven selection of comparison units. So sometimes in this field, sort of traditionally, people might just use every comparison state as a point of comparison, and I'll show you why that might not be ideal. Or maybe they might pick one or two, like, oh, let's compare Connecticut to Rhode Island, or let's compare Connecticut to Maryland, or some sort of maybe somewhat arbitrary selection of comparison states. So what this approach does is it uses baseline data, so no sort of post-law data. It uses data up to the point that the law was changed to weight these states and sort of provide the best comparison mix possible. There's also, again, some technical things that safeguards against extrapolation. So it basically ensures that we're comparing Connecticut with sort of a similar grouping of other states. So this shows the results graphically if we focus, oh, I'm supposed to use this. So if we focus on the left hand, so this shows the firearm homicide rate from 1985 to 2005 with the law change indicated by the vertical line. And first, if you notice the solid line, this is Connecticut's homicide rate, firearm homicide rate. This dashed line up here is all of the control states, so all 39 comparison states. And we can see that it looks pretty different. Those states had much higher, sort of on average, had higher homicide rates during the pre-period, which might lead us to question whether they really are going to give us sort of a good estimate of what would have happened to Connecticut without the law change. So instead, we're going to use the synthetic Connecticut, which is this dashed line here. And again, what this represents is a weighted average of the 39, where we up or down weight individual states in order to make these trends as similar as possible. And we see that here it's done a good job, that the firearm homicide rates in the pre-period look quite similar to Connecticut's. And then what we do is we look out into the post-period and compare Connecticut's rate with what happened in the synthetic control states. And we can see here that this reduction, that 40% reduction, is seen by the difference between this dashed line and this solid line. Again, sort of what we actually see in Connecticut with what we see in some states that sort of have been made to look like Connecticut. The right-hand graph is the non-firearm homicide rate, and we see no effect on non-firearm homicides, which is sort of a nice check that sort of the effects were focused on the firearm homicides, which is exactly kind of the thing that we would have thought should have been affected by this law change. Of course, studying a single state and a single policy change is very difficult. There's lots of factors that are happening, and sort of it's very hard to isolate sort of the effects of any particular law. So I think in this kind of context, it's also important to think about broader, sort of the broad literature more broadly, and sort of put together different pieces of information. So I'm not going to get into the details of this, but just sort of for your information, in this case, what we can do is also look at Missouri. So there's only 2 states that have had fundamental changes in their permit to purchase laws, Connecticut and Missouri. And Connecticut put in place a law in 1995. Missouri repealed their law in 2007. And what Daniel Webster and colleagues have found is that Missouri's repeal was associated with an increase in firearm homicides. So sort of as we would expect, when we put in place the law, there's a decrease. When the law is repealed, there's an increase. Similarly, for suicides, actually the same pattern is observed for suicides. And again, sort of piecing together these pieces of information help give us more confidence that sort of really it was the law making a difference in these homicide rates. So in terms of the synthetic control approach, comparative interrupted time series is often a very good and sometimes the best way to estimate the effects of interventions in broad populations. So if we're interested in what were the effects in the entire state of Connecticut of this policy change, this approach allows us to do that. And this synthetic control approach in particular helps us make sure that the comparisons are being done using comparable states in this case. What I'll turn to now, though, is sort of answering the question, well, what if we don't have a population change like this? Or maybe what if we have individual level data that we might want to take advantage of to estimate some causal effect? So I'll now turn to a second case study looking at propensity score methods conducted in sort of at least somewhat representative samples. So this connects, I can't give a talk in statistics now without mentioning big data. So this is my kind of connection there, but it's highly relevant for population inferences. So there's more and more sources of data on broad populations of interest. Large-scale electronic health record systems, this PCORnet system is a perfect example. Medical claims files, nationally representative surveys. We have various sources of data on broad populations of individuals. So the question is, how can we use this data to estimate causal effects in those broad populations, especially given that generally those treatments or interventions of interest won't have been randomized. So we just have non-experimental data. We have people going about their lives, getting records into the electronic health record system. How do we then use that to sort of tease apart causal effects? For example, the effects of a particular medical intervention or a particular drug, maybe the effects of environmental exposures. So propensity scores are one approach for doing this. So the main problem in non-experimental studies is that of confounding, that the people who choose or sort of end up receiving one treatment are different from those who receive a different treatment or comparison condition on lots of factors. So the decision to take a particular antidepressant might depend on a whole variety of factors, some of which we might observe and some of which probably are not observed. Propensity scores are one sort of key design tool for these sorts of studies. And the idea of propensity scores is to make these groups who received these different treatments look as similar as possible, at least with respect to the observed characteristics. So if we can sort of make people look as similar as possible, we can then compare outcomes and have removed the confounding due to those observed characteristics. I'll come back to this, but it does rely on a hefty assumption that there's no unobserved differences between the groups. But I'll come back to that. So to make this more concrete, I'm going to use an example of looking at the effects of psychosocial therapy after suicide attempt. And this was joint work with Annette Erlingson and others in Denmark. Annette is an affiliated faculty member in mental health. And the beauty of this study is it uses data from the entire country of Denmark. So they have wonderful registries in Denmark. And what we could do is use population data in Denmark to compare the outcomes of people who received psychosocial therapy after a suicide attempt to similar individuals who didn't. So Denmark was rolled out these suicide prevention centers across the country at different times and in different locations. And this study was designed to say, what is the effect of going to these suicide prevention centers, again, after an initial suicide attempt? So what do propensity scores do before we get back to the example? So in an ideal world, we could sort of control for confounding by finding similar people. So for every person who went to one of these suicide prevention centers, we could find another person who looks just like them on their pre-existing characteristics. In normal size samples, we can't do that. There's too many things that we want to control for, and we just can't sort of stratify or kind of exactly match on every variable individually. So propensity scores allow us to summarize all of the covariates into one number and then find these similar individuals based just using the propensity score. And we'll see in a second an example of how it then can give us groups that look similar on a large set of characteristics, even though we've sort of done the matching using just this sort of single number summary. So propensity scores in particular then attempt to replicate two features of randomized experiments. So the first is to make the groups look like they could have been randomized, at least with respect to the observed characteristics, so remove the confounding in that way. And then second is to not use the outcome when setting up the design. And this is my advisor, Don Rubin, this was one of his main points, that we want to be able to say that we didn't pick a particular approach to give us some desired answer. So we'll, just like we design a randomized trial without knowing the results, we'll design a non-experimental study without using the outcome data to sort of remove that potential bias. And I'm not getting into any of the details of it here, but much of my work is in how to use propensity score methods in practice, and for example, especially with various data complications. So missing values, complex survey design, large samples, etc. So to get back to the example, I'll just tell you a little bit more about the data. So this sort of data makes you jealous and think, if only. So in Denmark, they have these linked registries, which includes a civil register about where people lived. It also includes all familial information, so you can link people to their parents and their children. A national registry of patients, so you know the medical interventions that they were receiving. The psychiatric central registry, which has specific information about psychiatric disorders and interventions and treatments. And then also causes of death. So in this case, our treatment group are the users of suicide prevention centers. And again, so these are people who were admitted to hospital or presented at hospital following a suicide attempt. And some got referred and went to these suicide prevention centers and some did not. So we'll be comparing everyone in our sample will have had a suicide attempt, but only some of them actually went and got the follow-up therapy. And we'll want to know what are the effects of that psychosocial therapy on, say, later suicide attempts. So we have 30 years of data from 1992 to 2011, and about 6,000 people who went to these psychosocial therapy, suicide prevention centers, and 60,000 in the comparison group. So huge sample and very extensive data available on every one of these individuals. So what we did is for each user of the suicide prevention clinic, we found 3 individuals with a similar propensity score who also were exactly the same with respect to a couple key variables. And in the end, we were able to get, by doing this, by having this sort of treatment group and 3 comparison subjects, they ended up being similar on the 31 characteristics that we used in this process. So things like demographics, gender, age, educational level, SES, information on their previous suicide attempts, information on psychiatric disorders and diagnoses, and then also, amazingly, information on family history of suicide and psychiatric disorders. So I'm not going to show you all the details, but just to sort of show you, like, yes, propensity scores can work at creating this sort of similarity between the groups. It shows that more orange here. So the orange bar, each of these sets of bars is a characteristic. So age group, age over 65, a psychiatric diagnosis, whether they have children, male, urban, and working. So these are all binary variables. The orange bar are the non-participants, those who didn't go to the suicide prevention center. The darker blue bar is all, the orange bar is all of the non-participants. The dark blue bar are all of the participants. So the dark blue bar are the people who went to these suicide prevention centers. And so we see that there's some big differences. The orange bar and the dark blue bar are often pretty different from one another. This is the confounding unobserved characteristics. But the lighter blue bar shows that same characteristic, but just in our matched sample, just among the people who we picked as matches. And we see that the lighter blue bar is generally closer to the dark blue bar. So again, this is one just quick diagnostic to show that the matching worked in terms of creating groups that look more similar to one another. And again, this was true for all 31 characteristics that we put in, not just these few that I'm showing you. And what we find if we compare outcomes among the treatment group and then these matched controls is that this program was effective at reducing the 10-year risk of repeat suicide attempts, death by suicide, and death from any cause. There's a Kaplan-Meier survival curve to show, you can do these, sort of almost treat the data as if it was from a randomized trial in terms of the analysis. But of course, the concern is that, well, maybe there's just some unobserved difference, that the people who chose, they were more motivated, they actually went to one of these centers, they maybe sort of were healthier in some other way that's not captured by these 31 characteristics. So there's a body of research that has developed these sensitivity analyses that basically allow you to say sort of how strong an unobserved confounder could change our study conclusions. And so in this example, we're able to say, for one of the weaker effects, which was repeat self-harm after 20 years, a binary unobserved confounder with a prevalence of 0.5, sort of a little detail, would basically have to have a twofold association with participation in the program and with the outcome in order to sort of take away our results. And you can then have a substantive conversation about how plausible is it that such an unobserved confounder exists, given that we've already matched these groups on 31 things, including family history, their previous history, etc. So again, it can turn sort of a general concern about unobserved confounding into a more concrete statement where experts in the field can then say, how believable is this? How worried really should we be? So propensity score methods can be a useful tool for improving the estimation of causal effects. They can be used in large-scale population data sets, such as the Danish registries. And we can then draw inferences about that broad population of people. So across the country of Denmark, how much did the clinics reduce suicide rates among the people who actually used them? But non-experimental studies will still have this concern about an unobserved confounder that might actually be explaining the difference in outcomes. So I'll take just a few minutes to briefly describe some of my recent work on, well, can we get the best of both worlds? Can we combine a randomized experiment with population data in order to actually get a better population effect estimate? So some of this work was with Steve Cole, who some of you, I'm sure, know. He used to be faculty here in EPI, where we've been developing methods that, again, basically allow us to take data from a randomized trial and predict what impacts would be in a target population by combining data from the trial and the population. And we do this basically by reweighting the trial sample to look like the population on some observed characteristics. The characteristics it's particularly important to do that on are those that moderate treatment effects, because that's what's going to cause bias. Essentially, for example, if the effect of the treatment differs across racial groups and the trial had fewer minorities than the population, in order to estimate a broad population effect, you need to account for those racial differences. So briefly, this work, the one example I'll show, there's sort of HIV examples and others, but I wanted to connect back to my mental health and some of my initial roots in this field from many years ago. So Catherine Bradshaw and Tracy Wasdorp and Phil Leaf in mental health conducted a randomized trial of a school-wide behavior prevention program, or behavior program, in 37 Maryland schools. So it's this program called PBIS, Positive Behavioral Interventions and Supports. And the idea of PBIS is to sort of create a school climate that promotes positive behaviors. Sort of the kind of school environment you would sort of hope would be everywhere, but isn't necessarily. So they found in their trial that there were positive effects of this program in the 37 schools in the trial. The motivating question for my work and my extension of that was, well, what if the state of Maryland was trying to decide, should we promote this across the state? Should we sort of recommend that every school across the state of Maryland implement this program? And so what we'll do is we'll combine data from the trial and from across the state. So the first question is, how similar are the trial schools to those across Maryland? And I'm not going to get into the details, but we can see, for example, that the trial schools do differ from the schools statewide on some characteristics, especially, for example, the percent with limited English proficiency, some county sort of wealth and expenditures, and a little bit on some test scores. So the trial schools were not, from looking at this, you would say the trial schools are not reflective or representative of the average school in Maryland. But the question is, how much do those differences in characteristics matter? So the question is, like, if those factors don't moderate treatment effects, then it's okay. That sort of the effect in the trial might be fine for carrying over to the population. So the question is, sort of, if we adjust for some of these differences, do our trial schools look like schools across the state? So what we can do is use weighting approaches to say, if we re-weight our trial schools, the control group in the trial, do the outcomes we see match the outcomes we see across the state? If they do, that's showing that the weighting is sort of making our trial look like the state in terms of the outcomes of interest. So this figure sort of illustrates that, and I'll just briefly mention kind of how it illustrates that. So in this figure, let's see, which way should I do this? The solid blue line, the dashed blue line is the control schools in the trial. So these are the trial schools. The x-axis is outcomes at different points in time, so math test scores, reading test scores, and then suspension rates. The black solid line is the state population. So the difference between this dashed line and the black solid line is showing that the trial schools are different from the state, that they are not, just like we saw in the previous slide. But the blue solid line is the weighted control group. So once we've weighted the trial schools to look like the state on these characteristics, their outcomes actually match quite nicely. At least sort of 2 years out, 3 years out it gets harder, but 2 years out. So the observed characteristics allow us to better estimate what would be happening across the state if this program were implemented statewide. That said, it's not the most exciting of results. So what we find is that in the trial, they found, looking at this outcome called office disciplinary referral, so basically how often are kids sent to the principal's office. In the trial, they found a reduction in these ODRs of an odds ratio of 0.64. If we do a reweighting of the trial to look like the state population, we actually get a very similar effect estimate, 0.61. So our conclusion is similar, and this is often what happens. It's sort of, that in fact, we would think that if we did apply this statewide, we would actually see a similar pattern of results that we saw in the trial. Part of the reason for that in this case is that there aren't strong effect moderators in the trial, that sort of the effect doesn't vary a lot across different types of schools. And so we don't sort of see much change then when we do this reweighting. So in terms of these generalizability methods, again, a lot of my recent work has sort of been on this topic where I want to sort of help increase awareness that we can't necessarily assume that the average effects you see in a trial would carry over directly to some target population. But there are growing statistical methods that allow us to adjust for the differences in observed characteristics and estimate population treatment effects. However, this is only as good as the set of covariates that we observe. So actually with my current postdoc, Chiang Nguyen, who some of you know because she was a student in Health, Behavior, and Society, we are developing methods analogous to those sensitivity analyses for a non-experimental study, we're sort of developing those sorts of methods, but for this case, to say, what if there's an unobserved effect moderator? So I want to just take a couple minutes to sort of conclude and take a step back. So sort of an aside on data. Again, as I alluded to earlier, there's increasing interest in sort of big data, and there's lots of attention to, are you using big data? I get that question all the time. Would you consider yourself a big data person? And I want to just it's sort of obvious, but estimating population effects requires population data. So we have to know about populations. However, these statistical analyses may not look like they're using, quote, big data. So the Connecticut study, it had 600 observations total, 40 states, 15 years of data. So the analysis doesn't necessarily look like kind of big data, but the data underlying it was reliable data on homicides from across the country. So there was sort of big data, like high quality population data underlying it, but then the analysis ends up being done on 600 observations. Relatedly, in my work on this generalizability, one of the sort of limiting factors is often getting this population data, that it's hard to get comprehensive data on target populations of interest. And I'll say more about that on this slide. So again, there are more and more of these sources. So you might be thinking to yourself, oh yeah, well there's PCORnet, there's large-scale claims data sets from Aetna or Optum. There are more and more resources. There's large administrative data sources in some, especially for example in educational settings. But I've found, at least in my work, that there's huge problems in terms of measure comparability. So to do any of this, if we're combining different data sets, we need the measures to be comparable across them, and that's a major limiting factor. Publicly available data is also sometimes hard to come by. So if we have population data available and with measures that are comparable to sort of other sources, we can use this data to answer really important and more nuanced questions than we sort of can from just our standard, say, randomized trials. So estimating population effects can be challenging, but is often what we need to make informed policy decisions. There are a range of design options that exist, and again, a lot of that is what motivates my work, both sort of advanced randomized designs in representative or at least fairly representative samples, and then also non-experimental designs that allow population inferences. But hopefully combining sort of high-quality data, rigorous methods, and careful analysis can help us improve public health and public policy. So that is it, but I want to make one quick sort of side plug, which is that if you liked the ideas of what I was talking about, you should come to the Ross Royal Symposium on Population Inference. I neglected to say at the beginning, this is actually the centennial month for the Department of Biostatistics, which is well-timed and actually just coincidence. And as part of those events, we're hosting a one-day symposium with some really amazing speakers. Everyone we wanted to come agreed. And it's going to be a day long of talks on these sorts of issues about how do we estimate population or make population inferences, for example, when we don't have a formally representative sample. So there's a long website here. You can find it, I'm sure, on the Biostat Department webpage as well. But I encourage you to come if these sorts of ideas intrigue you. And there's my website and my email, and I'm happy to answer some questions.
Thank you. That was a great talk. And I'll just remind everybody that if you want to ask a question, if you want Liz's parents to be able to hear it on the podcast, you have to use a microphone. I also want to recognize Ray DiPaolo, who made the trek from across the street, chair of the Department of Psychiatry, to be here.
All the way across the street.
Yeah, thanks for coming. And I always love Biostats talks that are totally qualitative. It was really nice. So I'll ask the first question. I'm sure we have other questions. But so you didn't tell us, maybe I missed it. I was trying to tweet your talk, so I may have missed it. But with synthetic Connecticut, how did you do that? What methods did you use?
So the method, basically what it does is it has an optimization function, which is trying to make each of the time points in the pre-period as close as possible. And so it's a complicated algorithm behind the scenes that tries lots of different weights on the 39 states to see what combination of weights with some parameters and some kind of constraints give us the closest match to Connecticut.
I see, okay. And I just want to ask a question about Denmark here. So, so you had a big sample size. What the people who were in the control group weren't treated at a suicide prevention center?
Right.
Were they not referred to a suicide prevention center, or were they referred and didn't go?
It's a combination, and this was sort of the first initial paper, and Annette and her colleagues are sort of doing some more in-depth, for example, to even more specifically compare like what bundles of services did the people get. But the short answer is it's a combination. So a lot of it was actually that these centers weren't available everywhere at every point in time. And so some of the comparison group are just people who didn't have access. I think there's also some amount of just they didn't get referred, so they could have gotten referred, but they just didn't. And then certainly some were people who got referred, but just didn't actually go.
Did you have enough of a sample size to look at those separately?
I don't think we know who
whether
was
the effect-
referred. Yeah, I don't think we explicitly know that.
Okay, great. So any other questions or comments? Yeah, please use some more.
Thank you, Alice. Another short person. I have two questions. First one is following the synthetic Connecticut idea. So later on, you say that combining the observed population level data with the randomized control trial later on part of your talk, and you reweight the experimental group, or you call treatment group. I wonder why didn't you call that synthetic control, experimental group?
Great question.
It seems to me that is a parallel,
Yep.
Synthetic control group and synthetic experimental group.
Yep.
So that's,
I'll just quickly respond to that. So it's a great question. The distinction is that in the Connecticut example, there was one treatment group, there was one treatment state. So it's sort of, we're just trying to reweight to sort of make this to match the single state, Connecticut. Whereas in the propensity score, sort of the reweighting the trial, that was where we had just a bunch of people and reweighted them as sort of a group. So the behind the scenes reweighting is a little bit different because it's sort of one unit versus lots of people. But it's the same sort of fundamental idea. Yeah.
Thank you for that. And the second one is to do with the big data, and also to do with the Denmark data is the big data. And we're talking about all the problems with the randomized control trial. And you haven't talked about that. One thing is one direction is computational. So for example, use the research charge data, which is population level, and it's grounded on empirical. We can start with that data, estimate as much as we could, use causal inferences model and get the parameter estimated. After that, we can kind of like doing virtual randomized experiment, and then randomize whatever you like, and then use the parameter estimated to grow the model, so that we know that is under the absolute randomization situation at the population level, what the causal impact would be. So I would like you to mention, discuss just briefly on that.
Yeah, I'm not sure. I'll attempt an answer, and I apologize if it's not exactly getting to what you're talking about. But I think that's sort of what the PCORNet model is. So in some scenarios, we have this large-scale population data, like the Danish data I had. We couldn't actually randomize. So we sort of used propensity scores to try to make it look like it, at least with respect to the observed things. But we couldn't go in and actually randomize. So that's sort of one fundamental limitation of many of those large-scale data sets. However, like PCORI has this vision of using PCORNet in a way where you have that big, large-scale data, but you actually can go in and randomize, and you actually have the ability to sort of inform what clinicians say are doing, and you can randomize, do they get this encouragement to get a flu shot or whatever. And so it's sort of embedding the trial in that large-scale system. And I think that is, if we can do more of that, that will be wonderful, at least for some of these sorts of questions.
That's, you can base on the population characteristics to sprout agent. So
Right.
it's similar to that.
Yep.
I know we have a reception outside, so I don't want to cut things off, but I'll just ask one more question. So when I started in EPI, the whole focus was internal validity.
Right.
And then whenever a trial was produced that people didn't like, they would hammer on external validity.
Right, right.
And you said you have a framework to
Yes.
balance internal versus external validity.
Yes.
So it'd be interesting, we don't have to, we can talk about it over wine, but it seems to me internal validity is key.
Yes.
And
Yes.
so what good is external validity
Right.
if there's no
Right.
internal validity?
Yeah, no, thank you for letting me finish on that note, because it's a really important one. And I do a lot of this work in education, and they've kind of just tackled the internal validity problem. And so now we're like, well, you also have to worry about this. And they're very like, what? Like, we've just figured this out, and now you're kind of making us deal with something else. And some of the reviews, we are very careful in the language to say we don't want to improve external validity at the cost of internal validity. So that's sort of like the ideal, and the goal is to have studies that have both. Like that you don't necessarily, again, we don't want to say external validity is more important than internal validity, but at least have a conversation about sort of the fact that both are potentially important. It also, though, depends on the scientific question. So for a sort of very mechanistic scientific question, it may be that you really only care about internal validity. External validity will come in if we really are, though, interested in sort of expanding to some sort of target population.
Okay, well, please join me in thanking Liz for a great job.